second year resident nephrology. I'm presenting a case of history was given by patient itself. My patient ABC, 45-year-old male, Hindu by religion, teacher by occupation, resident of Muradabad, UP, born consanguineous marriage, father of one son, came to the hospital on 8th May 2023 with chief complaints of bilateral leg swelling since 5 months. History of presenting illness. I would like to take my history back to mid-January, till which he was apparently alright. At that time, in view of his hemorrhoid issue, he went to some local doctor for which he was given some injection for PR bleeding and hemorrhoid issue. 3 days post that, he suddenly developed bilateral leg swelling, which was sudden in onset, which was noticed first over bilateral ankle simultaneously. It gradually progressed over bilateral legs to bilateral knee over 2 days' time. He did not show up to a doctor as he thought it must be related to his standing during teaching hours. But during next 3 4 days, the swelling progressed to the scrotal region. This progressive swelling was not associated with dyspnea, orthopnea, PND, chest pain, cough, hemoptysis, abdominal pain, vomiting, jaundice. There was no aggravating and relieving factor. After 2 weeks of above episode, he noticed facial swelling, which he described as the swelling was first noticed by family member. Then in the next 2 days, he started developing abdominal heaviness issue, for which he showed to a local railway hospital, where he was admitted and took treatment for the same for 5 to 7 days, for 5 days, where he was told that he was leaking protein and was referred to gastroenterology department. He was admitted to a private hospital under gastroenterology department on in month of
He was leaking protein from the gut or from
certainly
urine. So why was he sent to gastroenterologist?
that's what I was.
You were told. Okay.
Details of the treatment at that time was not known by him, but during his stay at that hospital, he was told that he had some issue in kidney function, but doesn't remember the details about it, and then was referred to Central Railway Hospital, Delhi, where he was admitted for further evaluation and management. During that stay, he remembers that he was given injection albumin and some medication to decrease the swelling, and underwent tests for the diagnosis and details of which are not known, but was told that he needs to undergo kidney biopsy and was referred to our hospital for the same. At present, on arrival to our hospital, his only chief complaint was bilateral leg swelling. During this 3.5 month period, there was no history of hematuria, oliguria, anuria. There was no history of fever, chills, burning, micturition. No history of rashes, itching, joint stiffness, arthralgia, rhinitis, sinusitis. There was no history of headache, blurring vision, vertigo. No history of diarrhea, vomiting, blood loss. No history of stomach work, exercise. There was no history of IV prick, blood transfusion, and there was no history of multiple sexual partner test. There was no history of bony pain, weight loss, decreased appetite, or weakness. There was no history of any prolonged antibiotic use, or there was no history of any painkiller abuse or any indigenous medication ingestion. There was no history of any easy fatigability, weakness, tiredness, nausea, generalized itching, decreased libido, or hair loss. There was no history of dysuria, urgency, hesitancy, or there was no history of flank pain. In past history, he had surgery for hemorrhoid under alternative medication practitioner in 2000. Then again in 2000, he had some PR bleed episode but was managed conservatively. And then again in mid-January, he had the similar episode for which he went to that doctor for injection. There is no history of diabetes, hypertension, any coronary artery disease, thyroid disorders, coronary COPD or tuberculosis. Family history as such was not significant. Personal history, sleep, bowel, bladder, appetite is normal. There is history of smoking 1 to 2 cigarettes per day for more than 15 years, that is equivalent to 3 pack years. Mixed diet preference was non-vegetarian, and there was no other addiction history. And in drug history also, there is no regular medication intake history as well.
Any specific drugs that you will ask him for? One is that has he taken any medicines, which is a generalized kind of a thing. Knowing his history, would you be interested in some particular drugs that he may have taken? So you might ask a specific question in that direction. So, see, when you are listening to the history of the patient. You're sitting in the outpatient, so usually your brain starts ticking as to what is the likely diagnosis. And then obviously you will ask, if your brain is ticking and you're thinking that this is quite possible that this may be the diagnosis. So there will be some specific medicines which you will look at or ask this patient which may be related to what is likely diagnosis in this patient.
So, as per the history, related to a drug, I will ask NSAIDs, especially the code used in the suburban area phenomenon, because that must be related to some nephrotic issue which are being regularly used by patients. NSAIDs.
NSAIDs, okay. So what kind of NSAIDs use is associated with, say, proteinuria or nephrotic syndrome? Anyone? What's the usual history of NSAIDs intake for a patient who has got anyone?
For a longer duration, 3-4 years, having rheumatoid arthritis or osteoarthritis, and taking it for a longer duration.
Okay. Any other drug?
Drugs which might be related to causing FSGS, causing nephrotic syndrome, like
What drugs can cause FSGS?
Some drugs like heroin.
Okay. Okay. Any other drugs? Huh? Huh? He said bisphosphonates. Okay.
Mercury, heavy metals.
So how is gold and mercury taken?
In alternative medications.
So what kind of medications? Especially which have been recently fairly well reported from Ireland. Yeah, herbal medications used for beautification. So very commonly used by young girls and women. And they use these herbal, and what do they contain? They contain mercury in fairly high amounts. So that's been associated with this. Anticonvulsants. History of anticonvulsants. Some of these drugs are associated with specific drugs. I'm saying that some of these specific drugs which are known to be associated with increased proteinuria and adverse effects. Okay. What kind of disease has been reported with these herbal products with mercury? Any specific type of membranous? NEL1 membranous. And what are the other associated diseases which are associated with NEL1 in addition to the herbal drugs that have been prescribed recently? Malignancy is another important association which you should look at when you have NEL1 membranous nephropathy, if that is okay. Yes.
Summarize. A 45-year-old male with no comorbidities presented with a history of bilateral swelling which was progressive in nature, for which he was admitted in multiple hospitals for the evaluation. Recently was admitted in Central Railway Hospital where he was given some medication for decongestion and was told to undergo kidney biopsy. So with my relevant history, my syndromic diagnosis is adult onset nephrotic syndrome.
So adult onset nephrotic syndrome is your differential diagnosis?
Sir, I would like to keep minimal change disease as my first differential diagnosis, second membranous nephropathy, and third focus in multiple.
So why would you say minimal change disease as your first one?
Sir, MCD is common in children, but 15 to 20% cases has been reported in adult also. Second, then so the onset of minimal change is abrupt and with associated with massive proteinuria and nephrotic type picture with the abrupt onset. That is one thing. And then sir, with the history, as there is no hematuria, no hypertensive history or any medication for the hypertension being used in his case. So with all this, I would like to keep that. That's why I'm keeping minimal change disease as my first.
If you had 100 patients at 45 years of age, whatever you say,
So if in
you
that
biopsied all these 100 people, so what would be your commonest diagnosis?
membranous nephropathy. Membranous nephropathy.
I'm saying 100 people whom you described as no hypertension, no.
As per this age criteria, the most common cause is membranous nephropathy.
No, I'm not talking of age, I'm talking of your patient. Your patient, similar, 100 patients similarly. So if 100 patients were, so how many will have, say 100 nephrotic syndromes at 45 years of age with this kind of history? So what would be the commonest? You said membranous, how many? What percentage?
50 to 60%.
50 to 60. Anyone different?
So minimal change, I would say, if we consider between minimal change, membranous and FSGS, the fact that there is no hypertension and the overall clinical picture.
In this picture?
In this picture, minimal change I would like to
No.
know.
So what percentage will be minimal change, what percentage would be membranous and what would be FSGS?
So about 40 to 50% in such a presentation would be minimal change. And the
40
next,
to 50 will be minimal change. ये कौन सी सीरीज आ किसी ने तो किया होगा इस एज ग्रुप में मिनिमम चेंज
so otherwise, epidemiologically wise, then membranous would be maximum, that would be about 50 to 60%. And then FSGS, that would be about 20 to 30%. And the minimum would be the minimal change, by 10 to 20%.
about 15-20% would be minimal change disease, which is what is reported in adult onset nephrotic syndrome from PGI, LGPGI, many other institutions with large biopsies. They have reported usually around. There is an increasing FHS over the years when you look at biopsies from 70s, 80s to now 90s and 2000s, and then maybe subsequent to that. FHS seems to be progressively increasing actually, and it includes both primary FHS as well as secondary FHS. This is biopsy pictures, so many of them may not be, but predominantly done for nephrotic syndrome. So they will be, so FHS is increasing. Membranous remains about, I think 40 to 50% of these biopsies would be somewhere around membranous nephropathy. We're looking at nephrotic syndrome. We're not looking at glomerular diseases or, but nephrotic syndromes, yes. Out of this, age-wise, yes, I agree. You said minimal change disease doesn't have hypertension, doesn't have microscopic hematuria. No, yes, I agree. But what percentage of people with minimal change will have hypertension?
So in adults, sir, it has been reported hypertension around 15%, and with microscopic hematuria, also 15 to 20% in adult cases of MCD has been documented.
What's the incidence of essential hypertension at 45 years old? What's the incidence of hypertension?
30%.
Yeah, around 30%. So 30-35% will have hypertension anywhere in the India, especially at age 45. So you'll have some essential hypertensions as well. So hypertension in an adult would be reported fairly, not that uncommon. Microscopic hematuria.
In case of MCD, it is
Yeah,
you see
about 21% in one series. So these features are not uncommon. They may be present in a particular. They're not something like 0%, 1%, 2%. 21% of people might have microscopic lesion. The other thing now, which one is common and which one is also in the exam, this will become, you will have one patient definitely of nephrotic syndrome. All of you will have one patient. And in an adult, it becomes extremely difficult to sometimes pinpoint which one is. Obviously, you will look at, they will expect that you will give cogent answers for making one diagnosis over the other diagnosis. But if we were so good in picking up this diagnosis, then we would not be biopsying these patients like we don't biopsy children. But the very fact that we are not sure about these and we can clinically fail in making these diagnoses. And in fact, if you want to make someone feel very poor about himself in making these diagnoses, you can ask him to write your diagnosis here and then do the biopsy, and you find that the biopsy turns out to be something totally different. And then you might even laugh at that person. So, how a senior or junior it may be. In the exam, when you are saying it, so you must also add that clinically it appears that this may be the order in which I am saying, but the very fact that it is difficult to make this diagnosis on a ground, we may say that this is likely to be membranous. Second possibility may be FLGS, third may be minimal change disease, more from the point of view of its overall prevalence in an adult population in this age group. Hypertension, microscopic featuring, and others are not been documented in this patient, so we don't know much about that. But it's difficult to make the differential that these are three common diseases, so which one will it turn out to be ultimately would be by a histological biopsy. Okay. One point you said that he was given albumin. When would you give albumin in a patient with nephrotic syndrome?
Sir, if one is trying to decongest the patient for massive edema or any, if there is any fluid overload condition, and the
Every fluid overload in nephrotic syndrome.
After we will be giving diuretic, but if the diuretic action is not because it is protein bound.
So what dose of diuretic will you give? Well, it also depends on the dose of the diuretic. If you give an inadequate dose of diuretic, you say kidney function is normal, so you think 40 milligrams of furosemide may be good enough in that person with a creatinine of 0.8. This is a patient whose albumin may be 2, but he has a creatinine of 0.8, so you feel that the furosemide may be 40 milligrams will be good enough. But how would you know that whether there is adequate diuresis with? When you give albumin to such patients, does the albumin rise in a nephrotic syndrome? What happens to this albumin? Yeah, from the IV it goes into the urine, isn't it? So albumin will, very rarely would you see that. So what is the purpose of giving albumin in a patient with hypoalbuminemia?
If like giving the maximum dose of diuretic also, still if we are not, that there is not
So,
adequate diuretic.
how you determine maximal dose of diuretic in a patient who is hypoalbuminemic and is volume overloaded, edematous? He's got a scrotal swelling, so he had scrotal swelling, so the clinician must have been disturbed. The patient is disturbed. When you see swelling in your scrotum, then obviously patients get very disturbed. ये सबसे पहले तो बाहर की जब तक swelling कम भी हो जाती है, he's not happy because the scrotal swelling might take some time to get out. So he's worried. He says कि बीमारी तो जा नहीं रही है, आप कह रहे हो बेटा कुछ हो नहीं रहा. So he is concerned. So how will you diuresis such patient?
So in this case, sir, we will try to give diuretics in IV form because of the presence of gut edema. Also, the oral bioavailability of diuretic is low.
So where would diuretic act? Where does it act? whereas a furosemide diet. Thick ascending. तो concentration जो होनी चाहिए ट्यूब्यूल के luminal side पे वो determine करेगी ना कि ठीक. So how will you know how to get good concentration of?
Maybe it's because it is like protein bound, so that's why we prefer giving it with albumin so that the amount reaches to that region and then the diuretic can act.
So that is one good reason to give it. But where would you give it? Anyone? Where would you give it? Where would you give albumin infusion? Children, it's commonly given like that. And uric, do patients of nephrotic syndrome get AKI or not? They can get AKI, especially with minimal change disease, is not uncommon, especially in children and some adults also. Sometimes patients develop acute necrosis, and this is much more seen with minimal change disease somewhat than with other diseases, except with membranous, unless you have renal vein thrombosis or you have arterial thrombosis, then you will get an uric and you can develop acute kidney injury. But otherwise, with minimal change disease, no other thing involved but nephrotic syndrome, you can get acute kidney injury. So if patients are anuric and now you want them to get diuresed, that's where albumin would be extreme. Or you have a resistant to diuresis person who is not responding to highest doses of your diuretics. Then obviously again you would use the same formula that it is albumin bound, it will be excluded through, you will reach higher concentrations of this drug in the tubular lumen and the thicker central lumen. And that's where the dosages of these drugs act, and they provide that. So basically two indications for giving albumin. Otherwise, giving albumin to people who have proteinuria doesn't make too much of a sense because you're giving an expensive drug which is being lost very quickly in the body, and so protein increase in protein will have to be done by a dietary and a slow protein supplementation by the oral route rather than this expensive. The only other condition would be again resistant, and sometimes with acute kidney injury when they are bilateral embolism, which occurs with severe hypoalbuminemia. So these are usually severely hypoalbuminemic patients who develop acute kidney injury. So that's where it would be logical to use it. Since this was used, so that's why I came at this. I thought we should finish this discussion here itself because it's commonly used by physicians just because they find that the albumin is 2.5, 2.8 and they're diuresing with even small dosages. But many times you will find that many physicians would have given them 2, 3, 4 units of albumin infusion, which probably would not do much, were not needed also. And they haven't raised the albumin by the time they come to you again and you find that the albumin is still 2.1. Okay? So how will you proceed? आगे कुछ आपने और कुछ anything else?
I think another reason where you use albumin will be when you have low cardiac pressure, so you have patients who have low blood pressure. So we'd like to give albumin along with the diuretic, so that you can increase our cardiac pressure and have more of your furosemide reaching the OAT1 receptors or OAT2 receptors, causing more diuresis. You also commented on the fact that there was no decrease in libido. Right. So what happens to the libido of patients who are excreting a lot of protein? Does it actually tell you about the onset of disease, the type of disease? what happens to testosterone in patients or male patients? What happens to testosterone? They decrease. What happens to the sexual drive in patients who are nephrotic? Is it normal? Is it high? Is it low? And why? Nobody?
Protein binding proteins.
Actually, inhibitors go because the ultimate mechanism of action test on that again is protein bound when it reaches to the cellular level. So again, if the overall hypoproteinemia condition is there, the ultimate action of testosterone will go down. The amount of testosterone would be normal, but its final site of action is not actually taking place.
Yeah, so he's right. So there's something called as hypogonadotropic hypogonadism in patients who have nephrotic syndrome. So levels of testosterone will essentially stay same, but the site of action and the mechanism of action becomes different. Second is you commented upon the smoking. Is there any kind of a glomerular disease which you see more commonly in smokers? It's a very important part of the history.
Smoking is related to membranous nephropathy.
We can move out of membranous, we can move out of MCD. So, what does smoking do to the kidney? What does smoking do to the kidney? So smokers generally have a very high sympathetic activity. So they will have something called as a hyperfiltration injury over a period of time. That gives rise to maladaptive response. Yeah. So you have a maladaptive FSGS that can develop in these patients. Second common thing with smokers is that you have something called as an anti-GBM syndrome, which is more commonly seen in smokers, which is also a presentation. Some of them present as nephrotic syndrome. Next.
On examination, he was conscious, alert to time, place, and person. Weight was average, fair, weight 78 kg, height 180 centimeter, BMI was of 24.1 kg per meter square. Pallor was absent, ictus was absent, cyanosis was absent, clubbing absent, lymphadenopathy absent, edema present, grade 3 plus, and it was bilaterally pitting in nature. Blood pressure was 118 by 74 millimeter mercury in right arm supine position, 124 by 78 millimeter.
Swelling over the scrotum or not? Was there or you coming in? Okay.
In left arm, 124 by 78 millimeter mercury in left arm supine position. Pulse rate was 78 per minute regular, normal volumic, normal tensive, no radioradial and no radiofemoral delay. All peripheral pulses were fed. Saturation was 98% on room air. Respiratory rate was 18 cycles per minute. Abdominal thoracic JBP was not raised. On head to toe examination, hair growth was fine. At the time of examination, there was no facial puffiness, no xanthal asthma. Scrotal swelling was present, but I have described in systemic examination of observation. And PR was not urine. Urine dipstick was there.
Do you think he missed something in the examination? While he was describing the swelling, I think he missed something in the examination.
क्या बोला भाई?
No. Was there any tenderness that I missed that? Did you say was it tender or non-tender?
I think so.
Any significance of tenderness?
If the swelling is related to associated with cellulitis underlying the edema,
What else?
DVT with the massive proteinuria can be association.
The extent of it, I think you didn't describe the extent of it. while you are at edema, what I would suggest is important because the examiner is also thinking at that point of time. So describe all features of edema at that point of time, even if they go into a systemic kind of that you are looking at. This is an abdomen, this is an. So if you are describing edema, then it would be good to say that does he have anasaka? So which would mean that there is fluid in the cavities as well, and there is scrotal swelling as well. So then the question will not ask. He knows that you already sort of looked at edema in a complete manner, and then tenderness. So those are all associated things at the same time.
So urine dipstick was done, which was suggested pH was 6.3, specific gravity 1.020.
फिर abdomen discuss कर दिया. Urine
Examiner says, some examiners say that urine has to be incorporated before system.
before examination. Usually urine examination would be discussed after the physical exam.
As per history,
You must complete all the physical examination. कोई ऐसा एग्जामिनर मैंने कभी देखे होंगे जो पहले यूरिन एग्जामिनेशन मांगेगा. अमेरिका में आते हैं रिपोर्टें लेके मरीज साथ में जो है फिजिशियन के पास तब तक नहीं आता जब तक पूरी रिपोर्टें ना आ जाए. बट इंडिया में तो आई थॉट
the dipstick was only
I think describe the examination first. So you went from general examination and then.
So first of all, I would like for the systemic examination of abdomen.
Okay.
So on inspection, the abdomen shape was normally round, normal umbilicus, horizontal straight, position between xiphisternum and in mid of the xiphisternum and suprapubic symphysis. There was no scar mark, no striae, no venous prominence, no local swelling, no pigmentation. There was no puncture mark and no visible peristalsis. On palpation, normal temperature to touch, there was no tenderness, normal elastic feel, no localized lump, fluid thrill was absent, no organomegaly. Percussion, tympanic note all over the abdomen, shifting dullness was absent, and on auscultation, normal bowel gurgling sound was heard every 10 to 15 seconds, and there was no renal fluid and no venous. Local examination of scrotal swelling was done on a standing position, exposed from abdomen to knee. On inspection, there was bilateral scrotal swelling with globular shape, size approximately to the size of softball. Skin was slightly shiny, there was no redness, no dilated vein, there was no ulcer, no scar, and no discharge from the swelling. And there was no impulse on visible on cuffing, there was no impulse. On palpitation, there was no tender, normal to cooling touch, pain. It was purely scrotal swelling, and consistency was firm, non-reducible, and the spermatic cord could not be felt. On respiratory examinations, as such, didn't find any finding. There was no bilaterally no infrascapular fracture also not found. And the CVS
no effusion.
No effusion. And in the cardiovascular also, sir, as such, finding was CNS also, sir. All the eye functions were intact and there was no sensitive.
So when do you expect reputations in the course education?
Sir, like in a patient who presents in anasarca point of view, if there is massive proteinuria which is associated with fluid overload also, and the patient presents in dyspnea or some chest discomfort. In those cases, there can be presence of pleural effusion, and or sometimes it has underlying cardiac history also. In that case, because of the fluid overload.
So one is a cardiac, pre-existing cardiac disease. When else can you expect?
So if there is in our case, if there is associated ascites also, from there also there can be associated pleural effusion in that case.
You said about crepitations. I'm interested in crepitations. It's an interesting finding that you will have in your patients with nephrotic reputations. Because generally these patients are not in cardiac decompensation, generally. Unless there is a problem which we want to ask.
It is a diaphragmatic leak.
So when will you get crepitations when you have patient?
Pneumonia effusion, because these patients are prone to pneumococcal infections that can cause pneumonic effusion
Yeah, so if you have a consolidation,
around the
what else? So can you have a thrombotic lesion which can give rise to some kind of a lung problem? That will give rise to.
pulmonary embolism.
So what are the features of pulmonary embolism that you will see in patients who come to you with nephrotic proteinuria on examination?
The patient can be hypertensive, tachycardia can be present. On examination, the patient also looks toxic and very pale also. That. And on auscultation, there decreased entry also onto that side where the thrombus.
So where is the thrombus generally, in the arterial system or the venous system? The venous system. Why don't you have thrombus in the arterial system?
Yes.
It's always a venous thrombus, right?
Thrombosis कहाँ पे सबसे ज़्यादा होता है?
Pressures are lower, so there is more space between.
And then you can get emboli also from the legs. Usually. So they go to which system? They go into the venous system, isn't it? So can you get arterial thrombosis in patients with nephrotic syndrome?
Septal defect.
No, septal defects वो तो ठीक है नहीं. I'm saying arterial thrombosis. Venous thrombosis is more common than the arterial thrombosis, but you can get arterial thrombi as well in somebody's renal artery stenosis with membranous nephropathy. And in fact, we've had a patient who presented with severe pain on one side, and we found that his renal artery was thrombosed. Fortunately for him, we were able to thrombolize him locally, and we were able to save the kidney at that point of time, but ultimately he had to lose that kidney because it had undergone some damage which we couldn't, and he did lose the other kidney as well. So. But they can get arterial thrombi or arterial thrombosis as well. So both arterial and venous. Arterial can be catastrophic. Sometimes venous can be chronic. In fact, in some patients it may not present as acutely and all that. So it may be a chronic thrombosis, and many times you may not find it also. So they may not get pain and other things, and they usually you find it. Or sometimes this can be the presentation, and nephrotic syndrome is detected when you are looking for a cause for renal vein thrombosis, and you find that the patient is proteinuric, and then you do a biopsy in such patients and you find that this is membranous nephropathy, and that is being described. And in fact, during our training, I can tell you that renal vein thrombosis as a cause of nephrotic syndrome was much in fashion. And in fact, I remember one thesis at least presented from PGH Chandigarh, renal vein thrombosis as a cause for nephrotic syndrome. It was later on found that actually many of these patients had membranous nephropathy, which is what led to Okay, so the reverse was much more commoner than renal vein thrombosis causing membranous nephropathy or nephrotic syndrome. So if you look at older books of nephrology, renal vein thrombosis as a cause of nephrotic syndrome is common. It can cause, but then these were all associated with mercurial diuretics and causing renal vein thrombosis, and this was all membranous nephropathy basically being treated with those mercurial diuretics, which were fairly common in the early 70s and 80s. There were not many other diuretics available. So these were being used, and they were all one which was probably missed membranous nephropathy, which was a cause. So, but older history, renal vein thrombosis is more a manifestation of nephrotic syndrome rather than as a cause of nephrotic
Also, arterial thrombosis is more common in pediatric
syndrome.
age group as compared
Very
to
good,
adults.
very good.
Catastrophic apla is one situation in which you have.
So, where do you think your diagnosis is any different on physical examination, or you think it's
Still, sir, on examination also, still syndromic diagnosis remains.
the syndromic diagnosis remains nephrotic syndrome, but does your differential diagnosis make any different movement, or you feel it's probably the same? So you didn't add the urine examination. You said urine examination shows
So it shows 4 plus protein, glucose was negative, ketone was negative, nitrite negative, RBCs was negative, and liquid stress reagent was also negative with pH 6.3 and specific gravity was 1.0. So it was like 4 plus protein again, it depicts that there is nephrotic range proteinuria, and with the absence of RBCs, we are somewhere moving out the nephritic component also. Even by the other things, moving out diabetes.
you didn't have actually nephritic syndrome as a differential diagnosis. So your diagnosis is predominantly. When would you make a diagnosis of nephritic syndrome?
So if the patient presents with hematuria complaint or oliguria or
So
any
oliguria, hematuria.
and the patient is hypertensive, can be associated with edema and
So how is edema different in nephritic syndrome and nephrotic syndrome?
usually so the extent of edema will not be as compared to nephrotic. The extent of edema is not to that great. It can be around 2 plus, like not presenting as NSR for the edema. That can be one thing.
What doesn't present as anasarca? The nephritic cannot present as anasarca.
Can present it less.
So what is common in nephritic edema? When does edema occur in nephritic syndrome and nephrotic? So when?
In nephritic, sir, there is a overfill theory which leads to edema in nephritic because of the due to the inactive channels activity.
Because of anyone? Nephritic syndrome and nephrotic syndrome edema?
Edema is in the beginning in nephrotic syndrome. In nephritic syndrome, there is oliguria and then edema, and there is a pulmonary edema component also in nephritic syndrome, intravascular.
And edema in acute nephritic syndrome is because of what?
So renal dysfunction.
Salt and water.
Water retention.
Salt and water.
Salt and water. Because of decrease in GFR. Isn't it? Acute nephritic syndrome because there is reduction in GFR. And that's what leads to salt and water retention. And oliguria, hematuria and edema occur very, very quickly in these patients. By the time oliguria occurs, the patient has a decrease in the GFR and salt and water retention is up. And they become hypertensive. They can present with left ventricular failure. They present with hypertensive heart disease and all. Because hypertension is a very, very common feature of acute nephrotic syndrome. Nephrotic syndrome, when does edema occur? When does oliguria occur? Oliguria is a presenting feature of nephrotic syndrome. When does oliguria occur in nephrotic syndrome? Yeah. So they become first edematous and then severely hypoalbuminemic, and then they might become hypotensive, and then the acute oliguria, then they develop. So it's a onset in acute nephrotic syndrome is an abrupt onset, acute. That's why it's called acute nephrotic syndrome. Nephrotic syndrome, subacute, slow. So overfill and underfill theory, you were there. So I thought in nephrotic syndrome both theories were existent. So you said in acute nephrotic syndrome overfill. I thought nephrotic syndrome also was overfill theory. So it depends on. So what is true of underfill and overfill theory? So to which you belong to underfill or overfill? What's your take on this? And
Nephrotic both have present.
so why do you think edema occurs in nephrotic syndrome? We talked about nephrotic syndrome. What about why is there edema in nephrotic syndrome?
As said, there is loss of albumin and hypoalbuminemia, which leads to low oncotic pressure, and then due to that there is leakage of fluid from intravascular compartment to interstitial, leading to hypovolemia, which sends the signal to the for the sodium and water retention, leading to edema.
Any other reason? But there are people who are born with no albumin. They never edematous. And albumin. Then they don't have any edema at all. No albumin. So
In those cases, the overfill.
in those cases, so what is the overfill theory? What's the overfill theory? So which means there is primary salt and water retention. So how does primary salt and water retention occur in nephrotic syndrome?
Due to the dysfunction in the inner channels.
So intact channels. So intact channels are important for sodium reabsorption. Okay. So why do they become dysfunctional?
Lack of action of the brain natriuretic peptide action.
मैं समझ नहीं रहा हूँ कुछ मुझे नहीं समझ आ रहा क्या कह रहा है आपको समझ आ रही कुछ बताइए भाई आप मदद करो फिर so no he's right that there may be increased salt and water salt retention in patients so but why how would salt retention primary defect in nephrotic syndrome may be salt retention so how would salt retention occur in nephrotic syndrome because of
the tubules we block the epithelial sodium channel. With the activating slow sodium retention to take place because the protein is passing in the tubule.
no protein is passing in the tubule would do what?
It will plasmin related epithelial sodium channels will get activated and sodium retention.
मिक्स हो रहा है प्लाज्मिन कैसे आ गया इधर कुछ समझा नहीं
The voltage gradient changes to do something with the polarity or something. channels are wanted.
प्लाज्मिन भी है थ्योरी, बट बताइए कैसे, ये कहाँ क्या बता रही थी प्लाज्मिन, बता आपने पढ़ा कुछ प्लाज्मिन के बारे में? नहीं पढ़ा. Plasminogen is a serine protein, which is also because glomerular permeability is increased, so it's also. And then it is acted by urokinase like that and converted into plasmin. And plasmin, so there is larger concentration of plasminogen which comes in, and that is activated to plasmin, and higher concentrations of plasmin. Normally these are inactivated in the urine, but since there is larger amounts, they are not inactive. So plasmin, and that inhibits the ENaC channels, and so that's where the ENaC channels here, and there is increased sodium reabsorption related to plasmin. So that's one. There is the NH3 channels as well, where sodium and hydrogen are. So those are also activated in patients. So there is evidence to suggest that probably in many nephrotic syndrome, sodium reabsorption may be a primary defect in nephrotic syndrome rather than a secondary effect after the hypovolemia, hypoalbuminemia as a result of which causes hypovolemia. Starling forces के numbers पता आपको कि नहीं? वो याद रखना है, पढ़ेगा इस वक्त. So you should read about the Starling forces, what's the oncotic pressure at the capillary end, then the venous end of the capillary, then oncotic pressure of the interstitium. So those become important where you are talking about the fluid moving from vascular compartment into the interstitium, and then so those become important especially for. And after some period of time, these pressures get better. That's why edema does not continue to become so overwhelming in patients, and because of these pressures because hypoalbuminia, the albumin leaks from the capillaries into the interstitium. The interstitial oncotic pressure also rises. The hydrostatic pressure is as such lower, so they match each other, and therefore, after some period of time, edema settles into a particular level. So those factors are not the ones which will. And different patients may have a different, and that's where clinical medicine becomes somewhat, and sometimes you see some patients responding very quickly to the diuretics. When you have a patient who doesn't respond to diuretics, so what would you do? So you're given reasonably good diuretics. Make it up.
We can add, like if we have been
So
given
what would
furosemide, we can add other diuretics. Yeah.
Combination of diuretics to break the resistance of diuretic resistance which might occur. So combination of and diuretics may be used. So you could use a proximal site as well as somewhere in the furosemide or loop diuretics, and then maybe a distal tubular diuretic. That could be one. And a salt intake. I think that's something that you have to be very, very particular about. People are taking larger amounts of salt, so they may be cheating on the salt. So it's very important that many times when you are giving diuretic, they are not effective is basically because the patient. How will you know how much salt you are taking, or if you were to assess how much salt you are taking, how will you assess salt? 24 hours urine sodium. So that is how you will. So what's the amount of normal urinary sodium? So what's the amount of normal urinary sodium? So it will vary depending on how much salt you are taking. Okay? So depending on how much salt you are taking. So if you are like Anna Hazare and you are on a fast, then what would you, if you are not taking zero salt, so what happens to urinary sodium? If you for 4-5 days, 6 days you do not take any salt. What would be your sodium? Urinary sodium would be? Low is what? I don't know what is low. 50 is low, 100 is low. It is low is compared to what? 100 is lower than 200, 150. So 50 is lower than 100. So 50 is higher than 20. So what is 1? Yeah, less than 10. Yes, it becomes. In a normal person, if your sodium, you're not taking any sodium, your urinary sodium becomes usually less than 10. Sorry. And the higher levels of sodium could be depending on how much of sodium. So normal kidney, the beauty of this kidney is usually, which is not realized, and I think it's very important, is that you have a capability of excreting very small or no sodium at all, or very large extent. Same is with osmolality. You can go down to almost 100 or 50, and you can go up to 12. So the capacity of kidney, and even with decreasing kidney function, there's been again the adaptations which occur in these kidneys are that you are able to maintain sodium. Many patients with end-stage kidney disease, you get surprised. They come with a creatinine of 10. They're not symptomatic. They don't believe you. You tell them that your kidney function is 5%. They say, कोई तकलीफ नहीं है. You check their, except for urea and creatinine, the sodium is okay, the potassium is okay. You're surprised, this kidney function 5%. He's been carrying on with his kidney function. Swelling, in fact, there is no swelling. In fact, he looks more dehydrated or volume overloaded. What would he look like?
Dehydrated.
Huh?
Dehydrated.
Why would he be dehydrated? Why would he be dehydrated? Why would he be dehydrated? Yeah, we haven't asked a question on this side. Now, if the difference between normal kidney and a diseased kidney is, what's the difference between sodium excretion in the diseased kidney and the normal kidney? I told you normal kidney can go from 10, 400, 500 milligrammes. What happens to diseased kidney? They are not able to decrease the salt excretion. So, उनके घर वालों ने नमक को खाना तो बंद कर दिया उसका. But they continue to. So, in fact, many advanced stage kidney disease, you can bring down the salt. You admit them for 2 days, give them fluid, normal saline. The creatinine comes down there. And you look at their salt excretion, it remains the same. Salt excretion continues to be high in these patients, even when they are salt depleted. So that's the problem. And they have a narrow window. You keep on decreasing as the nephron numbers keep on going down. This creatinine from this sodium excretion, which was 10, it was 400. It keeps on decreasing. This huge variations which can occur from 10 to 400. This keeps on progressively decreasing and decreasing. So they will get into a small narrow lane, which will keep on dwindling. And beyond that, if you go down, their GFR goes down. If you go above that sodium level, they go into heart failure or fluid overload and so on. So they have to remain in that balance of salt. So that's the impact of progressive loss of nephron. In nephrotic syndrome also, your capacity to absorb salt keeps on going up and up. And that's the reason salt restriction becomes an important element in these patients, because they will keep on absorbing these salts. One is that because of low albumin and hypoalbuminemia and all that, their intravascular volumes, and the kidney feels, if the kidney function is good, the kidney feels that this is intravascular volume. So a lot of sodium gets absorbed from multiple channels through various mechanisms, which you can keep on reading also. Multiple mechanisms of sodium reabsorption in patients with. There is Starling forces acting even at vasa recta and all those forces. So those also create reabsorption of salt, alterations in nephrotic syndrome. So all of this will lead to increased salt. So diuretics become primary methods by which you take care of this edema, and salt restriction becomes an important element. How will you find what the diagnosis is? The kidney biopsy. You did rest of the test, the kidney functions were normal.
Yes, a kidney function was normal.
Albumin कितना था?
4.20.
Total protein
4.3.
4.3 and 2.2.
Total cholesterol was 306.6.
Okay.
Triglyceride 277.6. LDL 191.07. VLDL 55.5.
So ultrasound showed normal size kidneys and all. No, nothing. So we did a biopsy. Biopsy showed. It showed minimal change. That's why you made the diagnosis. I knew that it will show minimal change. I knew the diagnosis will be shown because he said the diagnosis is minimal change disease. He would have made a diagnosis of membranous otherwise. So I think even in the exam, it's very important that you may sometimes know the diagnosis because some friend of yours who was in that institution and he tells you कि भाई यार इसका minimal change है ध्यान रखो तो but you will get swayed. In fact, it will earn you a less marks. You'll get negative marks for this because what needs to be understood is it's not making the correct diagnosis. You're not being assessed for whether you make the diagnosis. In fact, you are. If you make it the right diagnosis, most likely the examiner will think, "भाई आपको पता था ये," and that's what my suspicion was that कि ये निकलेगा minimal change disease because you said that this is minimal change disease. Ordinarily, I would have expected you to make a diagnosis of membranous nephropathy, but since you knew the diagnosis, either you change the history and present it to a minimal change so that the examiner doesn't, but otherwise you will get caught in this. So this should not be done. It's a good example of not doing what you should be because you get swayed by your diagnosis that it is minimal change disease because there was no hypertension and because there was no microscopic immaturity and therefore you say the diagnosis is minimal change disease.
So I think you should always go with epidemiological studies and what's the globular disease which is common in that area. So
That's good. That would be. So I think your differential diagnosis should remain something that you can defend. It gets difficult to defend minimal change disease, then you will get into problems like this that somebody has told you. And if this gets into the examiner that somebody has already told you the diagnosis, and then you are discussing this, it's not that you know the diagnosis because in this, I don't think that making a diagnosis is as important. And as I told you that nobody can really predict these diagnoses. I told you that you can make anybody slip on this road. And therefore, you're not expected to do it because the examiner himself doesn't make this diagnosis. In his day-to-day life, he does a biopsy and then makes a diagnosis. So, you're not expected. But you're expected to give a cogent differential diagnosis to see whether your thought process is appropriate or not. With the kind of evidence that you've read, the various studies which have come either from India or from outside, and then you make these arguments.
It's not necessary for you to give 3 differentials. But FSGS will be very difficult for you to explain.
No, in fact, I would say that if you have one diagnosis only, then you could give one diagnosis, that this is my diagnosis and I would keep other possibilities. But in nephrotic syndrome, it is impossible to make a good predictive diagnosis as such. So I would also add, because you are usually caught on these, आप मुझे बताओ कि पहला some examiners are very insistent, नहीं बताओ मुझे पहला diagnosis क्या है आपका, and why do you say so? So they are a bit more insistent. So you should be having reasonable cogent, and in the end you can say that. So these are arguments, but I would feel that a biopsy would be essential and to make what the diagnosis is. And that is true that many times patients whom you think would present as membranous turn out to be minimal change, which is good for them, but many times you think this is minimal change, it turns out to be membranous. And sometimes you
In
face
this case, when he presented to us while going to just the investigation in Central Railway, there was antibody at 2 level. There was done, but it was negative.
negative. So membranous becomes.
And we also did
Still have about 30%.
Yeah, 30%. Other members. Yeah, I would feel that when you are discussing clinically these patients, it's important to keep the clinical perspective important rather than going what the histology is going. Don't worry about the histology. He is not going to fail you if you did make minimal changes, but he is definitely going to fail you if you make minimal change because you knew this was minimal change and then your thought process gets corrupted that this is minimal change. And you didn't say that you knew that, you knew it later on when
I was going through the investigation.
Sir, in
Yeah.
this case, like the patient is about 32 years. So, in
Bad,
yes, sir. Sir, as per
40.
45.
he is
I
45.
got 30. Sorry, that is fine. I was thinking if it is, I misheard it as 32. So, sir, in a case if it's a patient is about 30s in 30s, so as per the epidemiology, usually FSGS is slightly higher as compared to membranous.
Yeah.
But sir, in such a presentation where hypertensive history is not there, can we still say FSGS would be our first DD as per the epidemiology? Or
As I said that these are numbers which will favor one or the other, and microscopic hematuria, hypertension, and some, if there is a very clear-cut drug history, if somebody has a very clear-cut history of drugs which are associated with a particular disease, say like focal segment, somebody who is an addict with heroin or other things, you know that FHGS is much more commonly associated. Then obviously FHGS goes high into this. But otherwise it's all a matter of percentages here and there. So that's why I said that. But presentations might give you clues towards a particular diagnosis. And in this age group, like Vinan said, that you don't necessarily have to make a diagnosis of FHGS. 45 years of age, FHGS would be a less likely diagnosis, definitely. It would be much more less likely than, say, a membranous or a minimal change disease. So that's true. But it's not that it is non-existent. You have FHGS being presented at any age group. And you do biopsies and you will find that FHGS sometimes primary, many times after certain years of age, secondary FHGS. And when you see FHGS, please, for God's sake, look if this is primary or secondary. Now, how will you differentiate between primary and secondary FHGS if you were to look at it clinically? Clinically, FHGS. So FHGS can be primary FHGS, immune mediated. Secondary FHGS because of
Infection, drugs, or matter.
other causes of secondary FHGS. So clinically how are they different? If this biopsy was FHGS in this patient and he was hypertensive, so would you think this is secondary FHGS because of FHGS? Or you would think this presentation would be more like primary FHGS? Now I'm giving you a hint straight away. This patient gives you a history that he's been hypertensive for about 8 years, 10 years. And on biopsy, he presents with a similar nephrotic syndrome, hypoalbuminemia, 4 and 2.4, he's got edema, scrotal edema. And on biopsy, you find FHGS. So this FHGS is secondary or primary? Yes?
Sir, I would say it would be primary.
Yeah, it would be primary. Why would it be primary? Now you give me the reason also, na? Tukka nahi lagega. Huh?
So
Primary
in terms of the protein
severe protein.
there must be significant photocytopathy, which is
Proteinuria, hypoalbuminemia. Secondary FSGS does not usually produce this kind of swelling, such degrees of hypoalbuminemia, hyperproteinemia. Okay, so they are not asymptomatic for edema and nephrotic syndrome. But you find that there is proteinuria in the urine, but there is not much of edema. So clinically, when you see nephrotic syndrome, which is associated with swelling, not only swelling overall, but swelling over the scrotal, and all those kind of things are not present in. So clinically, you should be able to distinguish between primary and secondary FSGS. But what would be the best way to confirm whether it is primary or secondary? By electron. So when you do a kidney biopsy in a nephrotic syndrome, since you don't know what is going to come, minimal change disease and FSGS, it's important to do in electron. Because fusion of food processes, diffuse or patchy, is what will determine whether this is really photocytopathy of causing nephrotic syndrome or not. Okay, so it's very important for that purpose. So it's good to include electron microscopy.
and also in the secondary FSGS, the glomerular size would be slightly higher in maladaptive organisms.
But in primary FSGS also glomerular sizes are slightly, and it depends also. Primary FSGS may start in juxtamedullary, and that's where sometimes you miss it in the first biopsy. You may not, because you may not find it. That's why when you see photocytopathy, you are not sure whether this is unsampled FSGS or it is minimal change disease, because it may happen in the juxtamedullary. And juxtamedullary glomeruli are the bigger. They're bigger. So, yes, I agree. Compensatory hypertrophy which occurs in the glomeruli, and that's one of the reasons for secondary FSGS is decrease in nephron loss, probably whatever the disease may be, which may have caused it. So that's one of the reasons. Yes, glomeruli are bigger, but glomeruli are bigger here as well. And there may be other reasons also. Diabetes as a cause for secondary FSGS. Again, glomeruli are bigger than that. So how will you treat this patient? Minimal change disease.
So to start, we will have some general we will advise for general recommendations like salt restricted diet. If the kidney functions are on the normal side, not associated with AKI, we can add anti-proteinuric agents like ACE inhibitor or ARB inhibitors. Then, sir, to decrease the edema, we need to add diuretic for that to have the symptomatic relief.
This is a disease where if you get the biopsy so quickly, then you probably go and treat the disease, specific disease. You will not have to give antiproteinuric drugs and all that. Because many of these patients may not tolerate some of those ACE ARBs because they may be hypotensive. So usually this is a treatable disease, this is a short-lived disease, response almost invariably most people will respond. What's the resistance to steroids? What percentage of people will not respond to steroids?
10%.
Yeah, in children about 3% actually. 97% will respond to steroids, but in adults, sometimes could be 10 to 15%. Patients may not respond to steroids. First course of steroids. How long will you give the steroids?
For maximum 16 weeks duration.
Yeah, usually in adults you may require longer because proteinuria may take longer time to settle down. So you should not declare a patient as resistant till you've given these steroids in good dosages, 1 milligram per kilogram body weight, to a maximum of about 60 to 80 milligrams. So usually we would give it till about 16 weeks. And if they don't respond, then what would be your drug, second drug? If they don't respond, now you are talking of these 15%, 20% people.
So the second line will be calcineurin inhibitors and
Cyclosporin and tacrolimus. What else? Right? Genetic analysis. Yeah, okay. Yeah, he would qualify. Somebody who's got primary resistance in an adult, yes. In a child also would. If there is another family history, also that would again qualify for. If you haven't done a biopsy, you will do a biopsy in such a patient. In children, especially if they've been resistant to steroids and you haven't done a biopsy, then you would do a biopsy in such a patient before you go for second line, third line drugs. So the second line drugs you said are cyclosporine. There could be a debate on which one would a particular person choose based on his experience as well as what age group he is in. So I usually will not choose cyclosporine. I would do cyclophosphamide. In a 45-year-old person, I would give cyclophosphamide as a first line for second line drug for steroid resistance. One that in how common is steroid resistance? How frequent relapses in adults? See, in children, 50% will respond. Out of the 50% who will relapse, another 50% of them will go into frequent relapses, which is about 25% of the, and out of them again another 50% will become steroid dependent, or they will have secondary resistance to steroids and all that. So they will require some second form of treatment. So which is about 10 to 15% of the total first cohort of 100 patients of nephrotic syndrome. But in adults, how are adults different than children?
Relapse is around 50 to 60%. Patient will relapse.
You said steroid response rate is lower in adults, but say we talked about 85% or so is the steroid response. So this 15% have primary resistance to steroids. But relapses are uncommon, not frequent. They will usually respond. If you have a relapse in an adult after having given a course, he is responded also. You give cyclophosphamide. But I agree that the literature on this is predominantly in the children. In adults, these kind of studies have not been done in a randomized fashion that you will say that which one is better than the other. So, especially because these are smaller number of patients. Now, these are not large number of patients that we're talking about minimal change disease in adults, and so you don't have a randomized trial in which people have looked at them. So most of this data is basically, even steroids in adults is again predominantly data which has been taken from the children and response to that. But experience is fairly good enough, but there are no good randomized trials to say one drug is superior than the other. But by and large, I personally find that somebody who has got either a relapse after giving the full dose, more than they become Westerners. Like in US and UK, cyclophosphamide is scary to doctors. They don't use it as well. But in India, somehow we become friendly with cyclophosphamide. So people will argue that we haven't looked very intensely and maybe we missed malignancies or we missed, but follow-up of these patients to the nephrologist in India is by and large much better than, so a good clinician would pick up at least few patients who would come to him and would say that yes, he's developed a malignancy or a cyclophosphamide induced adverse effects and all that. So cyclophosphamide is a good drug for. You give cyclosporin to them, they become resistant to cyclosporin also. So when you withdraw cyclosporin, so they become cyclosporin dependent also. So you are not able to withdraw cyclosporin. So in the end, you will end up giving them cyclophosphamide also. But I agree that cyclosporin or tacrolimus could be a good drug. And then Children All India Institute has published a very good paper, the randomized trial in children, giving tacrolimus versus steroids as a primary treatment of. Because many parents are worried about steroids in children, and you talk about steroids and the mothers suddenly get up from the chair and say, then you thinking that they're going to get these, and if so they're worried about it. So tacrolimus from that perspective becomes, and they have shown that the results are similar, at least in short term. I don't think there is a long term database. Steroids have been used for at least last 50, 60 years, so there is long term data on steroids. Tacrolimus has not been used in that randomized fashion. So long term data on steroids in children is, but the primary response rates are similar to tacrolimus. So in adults, I don't think I have used tacrolimus as a first line drug in minimal change disease. I haven't. I usually would give steroids, and steroids have shown excellent results. There are side effects of adverse effects in adults also, so you'll have psychological disturbances, especially the more elderly people. If you have a 60, 70-year-old patient with minimal change disease, any diseases that you will look for 70-year-old person minimal change disease. You should look for other causes, diseases associated in elderly age group and all. So lymphomas and all, even in children, occasionally you should look for. So lymphomas would be another disease that you should be looking for in adults.
So what do you do to a patient who is not responding to anything? What happens to them? Right.
तो आपने नहीं एक दवाई आपने अभी बताई नहीं तुझे देखो ये आपने बताई साइक्लोस्पोरिन साइक्लोफॉस्फेमाइड हो गई और कुछ people have tried levamisole, but levamisole on a long term basis for somebody who is steroid dependent, want to keep in remission and all that, but somebody who is not responded at all.
So pediatric experience.
Pediatric, adults. So anything else? You didn't talk of rituximab. Yeah, rituximab. बात ही नहीं हुई ऐसे कैसे हो? So rituximab, but he says कि आपने रिटुक्स भी लगा दिया तब भी उसके बाद भी वो आ गया साइक्लोफॉस दे दिया साइक्लोफॉस डालो दे.
In such cases, because the prognosis, we have diagnosed the patient with MCD, and the prognosis of the patient in MCD is good. Landing them into ES and stage kidney disease is very less. So in that, rather
But
than
then you have somebody who's got 25 grams of protein constantly. What do you do?
Yeah, they will die if they are not able. If you are not able to cause remission in nephrotic syndrome, so you should. It's easy to say that you have read that minimal change disease doesn't cause chronic kidney disease, but they will die before they develop chronic kidney disease of the complications of huge nephrotic state. So the nephrotic syndrome itself will produce complications which will be, so therefore sometimes even when kidney function is difficult to do nephrectomy in a person whose kidney functions are reasonably good. In patients whose kidney functions are bad and you still have nephrotic syndrome, is easier to do, convince them that okay, you should do a medical nephrectomy. So how will you do medical nephrectomy?
So these inhibitors, diuretics and NSAIDs.
Okay. Anything else? What?
it's simple like a dinner
Denervation.
medical drugs.
नहीं ड्रग्स हो गई और कुछ नहीं. आपने मेडिकल डिनोवेशन का क्या करना?
Close to what you're about to say. Something else.
कोई रेडियोलॉजिकल प्रोसीजर जिससे कर दो. Embolization. Because especially when you have a patient who is moribund and there is such severe nephrotic syndrome, says 25 grams of protein, urea, you would want to quickly get into. So the quickest way of getting away from nephrotic syndrome would be by embolization. Actually, drugs might take long time and sometimes they're not effective. And even after using these drugs in large amount of dosages, you find that nothing happens. They continue to pass proteinuria. So you might have to do an embolectomy in these patients. Save them and then do a transplant. Anything else? Anything else? Any questions or anything?
So regarding albumin, like you mentioned that if the patient is usually, we can try in nephrotic and he's anuric along with diuretic, we can look for the diuretic response. In case if the patient then continues to be anuric or he presents in an anuric state, maybe nephrotic with an AKI. So usually in such conditions, we usually avoid giving diuretic considering the response that he is already anuric. So would you still suggest that we can?
Most of these patients are not totally anuric.
Yes, sir.
So they are usually oliguric. They produce 200, 300, 400 ml of urine. So they are usually oliguric. And you would have given them. Many of them may have been treated outside. In that sense, sometimes you are able to produce diuresis in many of these patients. And some of these patients might require 1 or 2 dialysis as well because their kidney functions deteriorate either anuric also. And they would. And you have done the biopsy. Biopsy shows only basically diffuse podocytopathy. At that point of time, you may not have picked up acute tubular necrosis. Sometimes they will have an acute tubular necrosis as well. And it recovers. Sometimes it might take a longer time to recover as well. So if you can produce some urine, and the best effort in that station would be to give albumin at that stage. Especially in children, that's where it happens much more commonly. In children, they many times do open up when you give diuretics along with albumin infusion.
So in case if we are seeing the response,
Hypotension is another what
yes,
Anand was talking about. It does change that state. It's very important to do that. Otherwise, much more commonly that I find why I wanted this to be sort of brought about earlier also was that many times you find albumin being given to these patients, and I feel that it's wastage of patients' money basically because they didn't require it to start with. They respond easily well to a combination of diuretics or you give an infusion of furosemide for 24 hours, 48 hours in high dosages, and they usually would respond and maybe add a proximal diuretic along with. And if they are hypokalemic, then add even an aldactone. And then you are able to reasonably get many of these patients to diurese reasonably well. And albumin would not be required in many of these patients.
So if we are getting response following albumin along with diuretic, is there like minimum number of days do you advise?
You would, the moment you get diuresis, then don't give it. I don't think you will require it. They will open up then. It's like acute tubular necrosis that you become, the renal recovery might take some time, but you are able to get a non-oliguric patient into a non-oliguric AKI kind of. But it's always good to have a urine output. Good for the nephrologist, good for patients. Urine output is important. So urine is, you can say, elixir of life from that perspective. So it's very, very important. Anytime you see patients, they come. Urine. So that's important. So I think it's important, and it is obviously should be important to all of us. Anything else? No questions. Thank you. It was a pleasure. आपके साथ lesson for today is don't know the diagnosis. The diagnosis is what?